Thank you for joining us today. The Oncology Nutrition Dietetics Practice Group is happy to present a webinar, To PEG or Not to PEG, Current Guidelines in the Head and Neck Cancer Population. Our speaker today is Dr. Heidi Ganser. Dr. Ganser has been an RD for over 2.5 decades. Many of that time was spent with oncology patients. Her research is focused on head and neck cancer patients, and she's going to be talking about that population today. So thank you very much for joining us. I'll turn everything over to you.
Thank you, Amy, and thank you to everyone for logging on and sharing part of your day with me. The topic, to PEG or not to PEG, is frequently discussed on the listserv, and for those who work in this population, it is likely a subject that comes up frequently. Hopefully today we will shed some light on the topic, although I will provide a spoiler alert. We may or may not be able to give a definitive answer to the question, to PEG or not to PEG. My disclosure statement, the presenter has nothing to disclose. Today, I will provide a brief overview of head and neck cancer for those who may not be familiar with the disease and the potential treatment-related side effects. I feel that this is important to have a background as it will lead into our discussion, although we will move through this information quickly. We will then take a global look at guidelines available in regards to head and neck cancer and then drill down into the specifics as they relate to nutrition guidelines and considerations for feeding tube placement in the head and neck cancer population. Then we will dig a little bit deeper and look into the literature as it relates to PEG placement versus NG placement and also proactive versus reactive feeding tube placements. And finally, we'll look at the literature in regards to overall considerations and the pros and cons of feeding tube placement. And as somebody who's done a qualitative research, I feel that I would be remiss if I did not discuss to PEG or not to PEG from a patient and caregiver perspective. We'll discuss some opportunities and barriers that nutrition professionals should be mindful of if patients do have a feeding tube placed. Lastly, we will look at 2 case studies and future opportunities for dietitians. The objectives today are at the conclusion of the activity, participants will be able to describe structures involved in head and neck cancer and nutrition impact symptoms related to treatment, identify key guidelines that are available to practitioners regarding the use of feeding tubes in the head and neck cancer population, identify which patients, according to guidelines, would be most appropriate for feeding tube placement and type of tube, such as a PEG or an NG tube, and apply evidence-based practice within their practice setting. Just a point of clarification, recognizing that there are different types of nasogastric feeding tubes or PEGs, I'm going to be using a generic term, NG tube and PEG tube, recognizing that some could be placed by interventional radiology or surgically placed, etc. I'm using an umbrella statement. Also, just so everybody is on the same page, when I refer to a prophylactic feeding tube, it is the tube that is placed prior to treatment starting. Sometimes this is called proactive, and it may also be a therapeutic feeding tube if needed prior to treatment due to obstruction, poor nutritional status, or inability to meet their estimated needs. A reactive feeding tube is placed after treatment has started. So now that we are all on the same page, let's get started. A diagnosis of head and neck cancer places patients at high risk for malnutrition. The impact of malnutrition on outcomes can be severe. Weight loss is a strong independent predictor, if not the strongest predictor of survival. Although estimates vary, weight loss in newly diagnosed head and neck cancer patients has been estimated between 35 and 75%. Additionally, in a large systematic review of 33 randomized controlled trials, Tradi et al. Assessed patients receiving concurrent chemoradiation for advanced stage tumors, and they showed a mean weight loss during treatment ranging from 6 to 12%, and 17% of patients experienced severe weight loss of greater than 10%. Additionally, the Tradi review reported an overall incidence of feeding tube use in the studies they reviewed of 19%. Undernutrition is associated with poor treatment outcomes, including but not limited to increased morbidity and mortality, increased rate of infections, poor wound healing, increased risk of recurrence, and overall poorer quality of life. So based on this information, it is not surprising that the nutritional goals include weight maintenance, and this is both during and post-treatment. Another goal is the successful completion of treatment without breaks. And even if patients are overweight or obese, it is important to minimize weight loss until fully recovered from treatment. And I think we have all as practitioners heard the comments from other healthcare providers, well, this patient's overweight, they could stand to lose a few pounds. This is not acceptable. And the other thing we'll talk about a little bit further is there's often a gap in knowledge from patients and expectations, especially if they are seeing weight loss during the treatment as a benefit. Weight maintenance during transition from enteral to oral intake is also essential if a patient has had a feeding tube placed. And this is for curative treatment. Of course, goals may be different with recurrence. Head and neck cancer accounts for approximately 3% of all cancers diagnosed in the United States. Although the proportion of individuals is small, the anatomical structures and the treatment have a significant impact on activities of daily living, such as eating, sleeping, breathing, and speaking. Head and neck cancers are anatomically located within the nasal cavity and paranasal sinuses, the oral cavity, pharynx, salivary gland, or larynx. Risk factors for head and neck cancer are tobacco use. This includes marijuana, frequent and heavy alcohol consumption, and using alcohol and tobacco together increases the risk of head and neck cancer. Alcohol works synergistically with tobacco, acting as a solvent for the carcinogens. As a solvent, alcohol enhances penetration of carcinogens into the cells of the oral cavity. Another risk factor is prolonged sun exposure. The human papillomavirus, particularly the HPV-16, although HPV 18, 31, and 33 are also associated with head and neck cancer, is primarily HPV-16. The Epstein-Barr virus, poor oral hygiene or dentition, gender, men are 2 to 3 times more likely to be diagnosed with head and neck cancer, although the incidence of women is on the rise with the HPV-associated head and neck cancers. Age, being greater than 50 years, although this has come down, it had been greater than 60 years in the past. And environmental occupational influence such as asbestos, wood dust, or paint fumes, consumption of mate, which is a coffee-like beverage often used in South America, and overall poor nutrition. Diets low in vitamin A and B vitamins has been associated with an increased risk of head and neck cancer. I wanted to point out a little bit more about the human papillomavirus, or the HPV-positive related head and neck cancer. The incidence of HPV-associated head and neck cancer has increased 225% from 1998 to 2004, and this could be in part to that is when they began to look for it. Roughly 70% of oral pharyngeal cancers test positive for the HPV-positive virus. HPV-positive head and neck cancer will surpass the incidence of cervical cancer, which is also associated with the HPV virus, by 2020. HPV-positive head and neck cancer is more favorable in regards to survival at roughly 80+% versus 57%, which with an HPV-negative option. And currently, HPV-positive and HPV-negative tumors are treated the same. However, research and clinical trials are ongoing in regards to treatment, such as de-intensification of chemotherapy by replacement with the monoclonal antibody Erbitux and de-intensification of radiation. I wanted to point out that there is also a subset of HPV positive cancers, and it's related to tobacco. And with tobacco exposure, there is independently associated with survival for both HPV positive and HPV negative cancers. And this just means that it levels the playing field if there is a tobacco history. Risk of death and cancer progression increases by 1% for each pack year of tobacco smoking. As pack years increase, survival decreases. I will not go in depth in regards to staging, as I'm fairly certain that if you're on the webinar, you likely have a good understanding of staging. But briefly, head and neck cancer is staged using the TNM model, for stage 0 to 4. The T indicates tumor size and or location and indicates the extent of the primary tumor. This is site-specific. The N defines the degree of lymph node involvement, and M indicates the presence or absence of distance met. So why does this matter to nutrition professionals? It's very important, and as we start talking about the guidelines, you'll see how this relates, but treatment is all based on staging. Generally, an earlier stage head and neck cancer, stage 1 or 2, is treated with a single modality such as surgery or radiation, but later stage head and neck cancers, stage 3 or 4, are treated with surgery, chemotherapy, radiation therapy, or a combination of these modalities. For more information on staging and treatment options, I recommend that you would look at the NCCN guidelines in regards to head and neck cancer. The next several slides, again, are provided for those who may not be familiar with treatment for head and neck cancer. This slide is one of the best overviews of the nutrition impact after head and neck cancer surgery, and it is an oldie but a goodie from the original Clinical Guide to Oncology Nutrition. And the bottom line to this slide is that the majority of surgery for head and neck cancer will have some impact, negative, on nutrition after surgery. Radiation therapy also has a significant impact on the ability to take nutrition orally. Within the first 10 days of radiation therapy, there is a significant reduction in saliva production, with estimates being between 50 to 60% reduction of normal salivary flow rate. Also, as a generalization, it is by week 3 that patients will really begin to feel the impact of their chemo and or radiation. And you can see lovely pictures here. These are very common side effects that occur with radiation therapy, which, as you again can imagine, will significantly impact the oral intake. The next 2 slides are common chemotherapies used for the treatment of head and neck cancer. And again, I'm not going to go through each and every one of these, but the bottom line is somebody has nausea, vomiting, taste changes, mouth sores, etc. One can imagine that this will again negatively impact oral intake. So keeping all of the side effects and the potential impact on nutrition in mind, this is what leads us to the bulk of our discussion today: to PEG or not to PEG. We will start with a global overview of the guidelines, what is available, and do they include information about nutrition and feeding tubes. The National Comprehensive Cancer Network, or NCCN, 2018, and these are updated on a fairly regular basis, at least annually, often more. Do they have information about nutritional management and is use of a feeding tube addressed? Yes, it identifies the need for close monitoring, a multidisciplinary approach, including dietitians, and I should also include speech-language pathologists, which play a very important role as well. It is accessible via a one-time registration. It is free of charge, and of course, it's all types of cancers, not just head and neck, but for today's discussion, head and neck cancer. And for the United Kingdom National Multidisciplinary Guidelines, do they address nutrition? Yes, and they also identify the need for a specialty RD to be part of the multidisciplinary team for treating head and neck cancer throughout the continuum of care. And there's a link to their information. The Clinical Oncology Society of Australia, or COSA, evidence-based practice guidelines for the nutritional management of adult head and neck cancer patients. And I just have to say how impressive the Australians are in regards to head and neck cancer work. But they do identify the dietitian should be part of a multidisciplinary team for treating patients with head and neck cancer throughout the continuum of care. The American Cancer Society Head and Neck Cancer Survivorship Care Guidelines, they recommend including a referral to a dietitian for dietary counseling and assistance. And the American Society of Clinical Oncology, or ASCO, endorsed the American Cancer Society Head and Neck Cancer Survivorship Guidelines. And again, a link to their information. Excuse me. Now let's drill down a little bit deeper, looking at specific guidelines as they relate to feeding tubes. And I need to point out that these are only guidelines. One must keep in mind that there are sometimes potential confounding variables. For instance, you could have a patient that perfectly fits within a guideline to have a prophylactic feeding tube placed, but the patient may refuse. And I'm sure that we might all have worked with specific providers that may not favor the use of feeding tubes in general. So again, looking at the NCCN guidelines for 2018 in regards to feeding tube placement. The NCCN does not recommend prophylactic PEG or an NG tube placement in patients with very good performance status. And you could use the ECOG or the Karnofsky score, and without significant pretreatment weight loss, significant airway obstruction, or severe dysphagia. They do recommend a prophylactic feeding tube, and again, PEG or NG should be considered if severe weight loss, which we also know as significant weight loss, of 5% over 1 month or 10% over 6 months. We also recommend prophylactic feeding tube placement if there is ongoing dehydration, dysphagia, anorexia, or pain interfering with the ability to eat or drink adequately, or if there's significant comorbidities that may be aggravated by poor tolerance of dehydration, lack of caloric intake, or if difficulty swallowing necessary medications. If there is severe aspiration or mild aspiration in elderly patients with compromised cardiopulmonary function, and in patients for whom long-term swallowing disorders are likely, including those anticipated to receive large fields of high-dose radiation to the mucosa and adjacent connective tissues. And I think that we will see a theme forming here, and again, a very significant and important piece. To maintain swallow function during and following treatment, patients who have had a feeding tube placed should be encouraged to take oral intake if they can swallow without aspiration. Alterations in swallowing function can occur long after treatment and should be monitored for the lifetime of the patient. The United Kingdom National Multidisciplinary Guidelines, they recommend a feeding tube placement and start medical nutrition therapy if undernutrition already exists or if it is anticipated the patient will be unable to eat for more than 7 days. Enteral nutrition should be started if inadequate food intake, and they say, or define this as less than 60% of estimated energy expenditure, is anticipated for more than 10 days. They also recommend just use of a standard polymeric feeding. They recommend a gastrostomy insertion if tube feeding is to be greater than 4 weeks. They recommend offering prophylactic tube feeding as part of locally agreed guidelines where oral nutrition is inadequate. And at this point, I just want to put a plug in for those locally agreed guidelines and discussions. If, as a dietitian, you have the ability to take part in a head and neck tumor conference, I would highly recommend this. One of the reasons is that these patients are being discussed prior to the treatment starting, so they would be on your radar much earlier than possibly just being put on the schedule when they're starting treatment. The other thing is that generally speaking, you would have the ENT docs, radiation oncologists, medical oncologists, speech language pathologists, people that are involved in the care. And again, that's where you can have that multidisciplinary discussion and really take part in the discussion of a patient's malnutrition, or if they have malnutrition, or if they need a feeding tube potentially. This is the time to discuss this. So again, if you have the opportunity to attend and be part of a head and neck cancer tumor conference, I would highly recommend it. Okay, moving along. Clinical Oncology Society for Australia, again, COSA, recommend a feeding tube placement be considered to improve nutritional status, cost, and patient outcomes for patients who have a T4 or hypopharyngeal tumors undergoing concurrent chemoradiation. And again, this is where you want to know where the staging is and the treatment modality. Other groups should be considered by the multidisciplinary team on an individual basis dependent on clinical factors such as tumor site, staging, effect of multimodality treatment, radiotherapy, treatment fields and dose, type of surgical procedure, nutrition status, dysphagia, and social support. The Royal Brisbane and Women's Hospital Swallowing Nutrition Management Guidelines for patients with head and neck cancer. They have something that is validated to assist early identification of swallowing and nutrition risk. It helps guide decision-making on proactive gastrostomy tube insertion, and it is before, during, and after treatment. And this, I know, has been discussed on the listserv, but I just wanted to point out this amazing schematic. And it would be something I would use in my practice, and it mirrors very much what I've done in my past life. But here, I wanted to point out they have high-risk patients, those that are oral or oropharyngeal bilateral chemoradiation, or nasopharyngeal cancer, hypopharyngeal, or an unknown primary and chemoradiation, or severe malnutrition at presentation, unintentional weight loss of greater than 10% in 6 months, a BMI less than 20 with unintentional weight loss of 5 to 10%, and a dietitian assessment. They use the SGA with a score of C. And if any patients fall within this group, there's concurrent referrals to a gastroenterologist for the insertion of a prophylactic PEG to remain in situ for a minimum of 3 months, and also referral for a speech language pathologist and dietitian assessment. So pre-treatment management, and then a baseline barium swallow study and swallow rehab. And again, this is so essential. We'll talk a little bit more about potential risk for dysphagia in a little bit. But weekly review by the speech language pathologist and dietitian. And again, this is so important. In my past life, this is a Heidiism, and I apologize for going a little off topic here. But the dietitian and speech language pathologist would go in and meet with the patients together, and we would reinforce what each other was talking about to the patient throughout treatment. So again, weekly review. And then for any other patients, they still have the speech language pathologist and dietitian monitored, again weekly, but if they have not had a feeding tube placed, but their intake drops below 60% for greater than 10 days, a PEG should be placed if anticipated to be greater than 4 weeks, or NG if less than 4 weeks. And then following post-treatment for 6 weeks. And then this is essential. Review by a speech language pathologist and dietitian 3 months post-treatment with team consensus to remove the feeding tube, whether it's a PEG or an NG. And again, I think that this is so essential to have the certainty that swallow function is safe and that they are eating enough to maintain their weight. And then ongoing review by speech language pathologist and dietitian for a minimum of 6 months. The other item that I really like about their work is that factors for consideration during treatment. They point out several items to really be aware of. And then they also discuss factors for consideration post-treatment, and these are potential late effects that patients may experience. Okay. So now that we've seen the guidelines specific to the nutritional management and consideration for feeding tube placement, let's drill down a little bit deeper to determine if there's specific guidance in the literature in regard to the use of a PEG versus an NG tube. And I do have to say that there is not a significant amount in the literature related to PEG versus NG. There is a challenge as that some of the studies use, quote, a generic tube feeding description versus specifying whether it's a PEG or an NG. In a review of the literature by Bradley et al., they assessed the role of use of feeding tube in the management of head and neck cancer patients. They also looked at the indication, timing of insertion, advantages and complications, and quality of life issues. The authors conclude that overall, in regard to the timing of the placement, proactive versus reactive, there is a lack of evidence as to the best approach to optimize nutrition. In regard to prophylactic feeding tube placement, there was noted advantages such as reduced weight loss, reduction in unplanned hospital admissions and length of stay, which could lead to reduced costs. But they also conclude that reactive nasogastric tubes have been placed without significant issue. When they assessed quality of life, the authors found that there was improved quality of life at 6 months with a prophylactic feeding tube. However, some studies identified lower quality of life with feeding tube dependence. The review concluded that there is a lack of consensus about when and which enteral route should be used. In 2014, the Canadian Agency for Drugs and Technology looked at 2 questions. What is the clinical effectiveness of NG feeding tube versus PEG for patients with head and neck cancer? And what are the evidence-based guidelines regarding the use of an NG tube in an outpatient setting for head and neck cancer? 9 studies were included in the review. For question number 1, the results showed the PEG was superior to traditional use of NG tube when employed on an as-needed basis. There was lower tube dislodgement, and it was more suitable for longer-term use, which they deemed greater than 30 days, and improved mobility, enhanced cosmesis, which just means it was better for the patient, and overall improved quality of life. The negatives were that the PEG was associated with a delay in oral diet, prolonged duration of radiation therapy, increased incidence of pain and dysphagia, and increased cost. The answer to question number 2, recommendations are not specific to an outpatient, and often a generic quote tube feeding versus NG or PEG was used or cited. So the conclusion for question number 1 was that the current evidence is unable to demonstrate superiority of one method over another. A 2013 Cochrane database of systematic reviews assessing enteral feeding methods for nutritional management in patients being treated with radiotherapy and/or chemotherapy. Their objective was to compare the effectiveness of different enteral feeding methods used in the nutritional management of patients with head and neck cancer receiving radiation or concurrent chemoradiation. Clinical outcomes, nutrition status, quality of life, and rate of complications were assessed. Interestingly, only one study met inclusion, and this study was found to have a high degree of bias. Results show that weight loss was greater in the NG group at 6 weeks post-treatment versus PEG, but at 6 months post-treatment there was no significant difference. Duration of feeding was significantly longer in the PEG versus NG group, and the cost of the PEG was much greater. The authors indicated 10 times more than the NG tube, although this was not a significant finding. The authors conclude that there is not sufficient evidence to determine the optimal method of enteral feeding for patients with head and neck cancer. Lastly, a study by Corey et al. Compared PEG versus NG tubes and assessed nutritional outcomes, complication, and patient satisfaction. There were 32 subjects in the PEG group and 73 in the NG tube. Results found that the patients in the PEG group had significantly less weight loss 6 weeks post-treatment, with a median 0.8 kilogram weight gain versus a 3.7 kilogram loss. However, there was a high rate of site infection at 41%, longer median duration of use in the PEG versus NG tube, 146 days versus 57 days, and more grade 3 dysphagia at 6 months, 25% versus 8%. Patient self-assessment indicated general condition, and quality of life scores were similar. Costs were significantly higher in the PEG patients, so the authors conclude that the PEG use should be selective and not routine. Now let's dig a little bit deeper and again look in the literature to see if there is information about the benefit of proactive versus reactive feeding tubes. Soria et al. Assessed 40 patients with head and neck cancer that were identified with moderate or severe malnutrition. Patients were offered a prophylactic feeding tube, PEG, or an option to place an NG when and/or if needed. The results: there were no significant change found between groups in regards to weight, BMI, or serum protein. Energy delivered was above estimated energy expenditure in both groups, but there was no difference in total energy provided by enteral nutrition between the groups. The PEG group received enteral nutrition for a longer period of time. The authors conclude that both PEG and NG feeding tubes were effective, and there was no difference between them in terms of avoiding further nutritional deterioration. In another study by Brown et al. In 2016, subjects were predominantly stage 4 oropharyngeal cancer patients receiving definitive concurrent chemoradiation with a curative intent. There were 130 total subjects. 69 patients received a prophylactic feeding tube, and 61 were in the quote no PEG group. And you'll see why I included them in this group, as a fair amount ended up with a reactive feeding tube. Results found statistically significant less weight loss in the prophylactic PEG group and more unplanned admissions in the no PEG group. Interestingly, in those patients in the quote no PEG group, 26 patients, or 43%, did require a feeding tube or had a greater than or equal to 10% weight loss. The authors conclude that prophylactic PEG improved nutrition outcomes and reduced unplanned hospital admissions. In a 2014 study by Kramer et al., a total of 74 patients undergoing concurrent chemoradiation for head and neck received either a prophylactic PEG before treatment or a reactive tube after treatment had begun. Results found that in those patients receiving a reactive feeding tube, they had them in place for fewer days versus the proactive feeding tube, 139 versus 227 days, and there was no difference found in percent weight loss at 2, 6, or 12 months. There was no difference in survival or disease control between the groups. The authors concluded that a reactive PEG tube placement may allow for a shorter duration of feeding tube usage without incurring greater weight loss or poor outcomes. In a retrospective study by Lewis et al., 109 patients with stage 3 and 4 head and neck cancer had undergone standard concurrent chemoradiation. The study assessed outcomes in those who had a prophylactic feeding tube place, reactive feeding tube, or no feeding tube place. Results indicated that in those patients with the prophylactic feeding tube, there was significantly less weight loss, fewer nutrition-related emergency department visits, or hospitalizations, and a higher proportion of chemotherapy cycles completed when compared to a reactive or no feeding tube. At 12 months post-treatment, there was no relationship between the use of the prophylactic feeding tube and feeding tube dependency. The authors conclude that use of a prophylactic feeding tube produced better outcomes when compared to both reactive or no feeding tube group, without higher rates of long-term dysphagia and feeding tube dependence. Lastly, a review of the literature assessing prophylactic PEG placement by Locker et al. Concluded that there is insufficient evidence to make any recommendations whether prophylactic PEG placement in head and neck cancer patients results in a net benefit to patients. They also indicate that even though studies may have similar results, they often reach different conclusions. So we've covered a lot of literature, so let's summarize. In regards to whether it is better to use a PEG versus NG, 3 of the 4 studies discussed indicated that there was insufficient evidence to support one method over the other, and 1 indicated the PEG use should be selective, not routine. Of the 5 studies discussed in regards to proactive versus reactive feeding tube, 2 supported the use of a prophylactic feeding tube placement, 1 indicated that there was insufficient evidence to make a recommendation, 1 indicated both prophylactic and reactive NG tubes were adequate to meet needs, and 1 supported the use of a reactive PEG placement. And then lastly, to summarize some of the information we've discussed a little bit, but just kind of to wrap things up, gleaned from the review of the literature as it relates to the pros of a prophylactic feeding tube placement. The following have been specified: reduced weight loss, completion of more cycles of chemotherapy, earlier initiation of nutrition support, and we'll talk about this a little bit more when we look at qualitative research, that this actually can lead to more compliance and confidence with patients, improved nutrition and hydration status, improved quality of life, reduced hospital admissions, and a decrease in healthcare costs. Conversely, a review of the literature also found the possible concerns in regard to feeding tube placement, such as pain, infection, or leakage at the feeding tube site, need for feeding tube replacement, occlusion of feeding tube or dislodgement of NG feeding tubes, and perforated bowel. Also, there has been concern about longer-term feeding tube dependence post-treatment with the PEG placement related to increased incidence of dysphagia. There's also some concern regarding seeding of metastatic tumors with the pull-through method. And then lastly, the cost of feeding tube placement, especially if the feeding tube is not used, has been identified. And although several studies indicate lower cost for prophylactic feeding tube, and we'll discuss specific examples of head and neck clinics led by dietitians, we might be able to show a counterbalance to this. And it should be noted that mortality rates from gastrostomy tube placement from a meta-analysis of head and neck cancer patients has been reported to be somewhere between 1.8 and 2.2%. And I just want to make a comment about the concerns regarding longer-term feeding tube dependence post-treatment with PEG placement and the increased incidence of dysphagia. Oftentimes, studies do not discuss if there is a dietitian or a speech language pathologist involved, but I wanted to point out, and I do have it on my slide as a reference, Denaro et al. Has a really nice article on predictive factors as they relate to dysphagia, such as T and N stage, primary site, type of treatment, extension of treated regions, patient characteristics such as a baseline swallowing function and performance status, etc. And recognizing that these factors are there, perhaps starting intensive rehab swallowing therapy with pre-treatment swallowing exercises may improve post-treatment swallowing function. Their article has some recommendations for early diagnosis and might be used as a guide for a multidisciplinary team. Okay, so we have discussed a global view of head and neck cancer guidelines, looked at guidelines specific to the nutritional management of head and neck cancer and feeding tube placement, reviewed literature that assesses the use of a PEG versus NG, prophylactic versus reactive, and the possible pros and cons of placement. So the bottom line is that there is no agreed upon consensus on indication, timing, and long-term nutritional and functional benefit of tube feeding in patients undergoing treatment for head and neck cancer. But I do hope that I have given you some food for thought. There is another important aspect in the decision to place a feeding tube or not, and this is from a patient perspective. As mentioned, a feeding tube does have an impact on quality of life, although studies are mixed in this regard as well. Several studies indicate a positive impact of quality of life, especially as patients are going through treatment or at 6 months. Longer-term use or those who are dependent on a feeding tube show less favorable results. I wanted to point out one study by Osborne et al., who actually had 51 participants that had a PEG placed during their treatment. 84% of the participants in the study felt that the PEG had a positive or neutral effect on their quality of life. 90% felt this was very much or quite a bit worthwhile, and 96% would recommend a PEG to another patient, and that kind of speaks volumes. And another item to keep in mind if a feeding tube is placed is what are the barriers to compliance or desire to having a feeding tube placed? It may be the approach. If patients are educated about the process, it takes the fear factor out of it and they can make a more informed decision. If patients are more, and I say threatened, I don't mean threatened, but by stating if you lose too much weight, you'll get a feeding tube, they may be less likely to be open to the idea if they aren't given all of the information, but just told if you lose weight, you're going to get a tube. And again, I've mentioned already the two confounding variables that even if a patient does meet this criteria to have a feeding tube placed, they have the right to refuse. And again, there are certain providers that just might not be in favor of feeding tube placement. So if a feeding tube is placed, it is essential to remember the caregiver. When the patient and or caregiver are in the office or the clinic, they are going to feel much more confident and comfortable because, of course, they have the healthcare staff around them. And we need to be very mindful that at home it's a very different story. As healthcare professionals, we need to be cognizant of the fact that tube feeding at home does require physical, practical, emotional, and psychosocial adjustments within the home. Education is key. A perceived benefit of a feeding tube placement eases establishing a routine and increases confidence for the patient and the caregiver. And it is also important that we as clinicians focus on the impact that this will have on daily living, not just clinical outcomes. And dietitians, from my perspective, I could be biased, is that we are really good at doing this. We are also very good at determining challenges with the feeding tube if it is placed. In a qualitative study by Brown et al., they identified common patient-reported barriers to enteral feeding, such as feeling full quickly, nausea, treatment-related factors, reflux, and time required to administer the feedings. And again, this is where dietitians shine. We can be part of addressing all of these issues to maximize, again, that compliance and the confidence. And then one additional item that I wanted to point out, we talked about a little bit earlier, is that patients have this perception that they are, quote, not having a problem eating during treatment. And often there's a gap between patient knowledge and underestimation of their nutritional needs. It may also reflect conflicting goals in regards to weight management between the patient and the clinician, where a patient has perhaps their whole life tried to lose weight, and now this is a perceived benefit. Again, having that discussion with the patient and ensuring that they understand the impact of weight loss during treatment. As mentioned earlier, qualitative research has found that patient and caregivers may have a different perspective on having a feeding tube placed. The patient may have a more favorable outlook, while the caregiver a less favorable outlook. This may be due to the fact that the caregiver's life is impacted. Their daily activities may be disrupted and changed. And the patients are aware that they're going to be, quote, in it, because they're going to be having to go to appointments, going through treatment, etc. But again, the caregiver is very much impacted. The patient, interestingly enough, has, in a study by Meyer-Chilton, patients had a more favorable viewpoint in regards to cooking, while the caregivers really stressed over this. And this makes sense, and I'm guilty of this as myself, trying to give information and recipes, etc., to fortify and increase calories and protein. And I think caregivers take the weight of the world under their shoulders, and they're really trying to do their best, but this can be very stressful. The other thing is that, as everybody who works in this population knows, that one thing is good one day and not the next. And so there are so many trials, and the caregivers, again, are trying to best meet the needs of the patient, and it can be really challenging. Also, patients had less favorable views of oral nutrition supplements, where the caregiver thought that they were awesome because it was an easy way to get calories and protein in. In regards to feeding tube placement, there was agreement between patient and caregivers in the study that the feeding tube would help with weight management, and they both recognized that they would not have survived treatment without the feeding tube. Both the caregiver and the patient had concerns and difficulty when it came to weaning off the feeding tube. However, there was agreement that timely nutrition management, again, this is where dietitians can shine, help wean off the feeding tube with more confidence. Finally, in regards to feeding tube placement in general, it is important to keep in mind predictive factors, as mentioned previously, in regards to feeding tube dependent post-treatment. Those who are older, male or living alone, those who may have heavy alcohol use or with significant preoperative weight loss. And I just wanted to point out that in regards to when a feeding tube should be removed, in general, when swallowing has been assessed to be safe. And again, I'll go back to the Royal Brisbane schematic. I think that is an excellent example of some guidelines. And this could be site-specific, but when a patient is consuming adequate oral intake to maintain weight, and when a feeding tube has not been used for 4 weeks. And again, these are just general guidelines, recognizing that often it's very site-specific. All right, now that we have discussed so much of the literature and looked at guidelines, let's look at a couple of case studies. In case study number 1, we have a 64-year-old male with a stage 4 T4 N2B MO oral cancer, HPV negative. His treatment will include surgery and chemotherapy consisting of weekly cisplatin, radiation therapy, which is bilateral, for 7 weeks, 5 days per week. He has had a weight loss of 12% in 6 months. His BMI is now 19.7. He has a history of tobacco use and quit 5 years ago. He has a history of alcohol use, although currently he reports that he's only drinking 4 to 6 beers per day, and he is not going to give this up. He is divorced. Social support is lacking, and per the patient, his intake is poor, and he acknowledges that he doesn't like to cook, and at this point in time, he is not going to learn to cook. Overall, he has poor performance status, but he is able to do most of his daily living routine. Oops. So in regards to case study number 1, it is fairly straightforward. When looking at the guidelines discussed, this patient would be a candidate for a prophylactic feeding tube. He has oral cancer, a larger tumor, concurrent chemoradiation with bilateral radiation, weight loss prior to treatment. Things to consider: this patient should be monitored closely. He is older, male. He is currently using alcohol. He lives alone with a little social support, which places him more at risk for feeding tube dependence. Speech-language pathologists and nutrition should be involved. The speech-language pathologist should provide pre-treatment, swallow or rehab swallowing throughout the continuum of care. In case study number 2, we have a 40-year-old female with a stage 3 T3N1MO oropharynx cancer, HPV positive. Her treatment also includes surgery, chemotherapy, weekly cisplatin, radiation therapy, 7 weeks, 5 days per week. She has been trying to lose weight because she felt she was overweight, and she has had a 3% weight loss in 3 months. Her current BMI is 26. She has not used tobacco or alcohol. She does have prediabetes, and she is married with excellent social support. She is motivated to maintain her intake, and she is, quote, trying to bulk up and regain the weight prior to her treatment starting. So this is not quite as clear-cut. She does have a larger tumor with concurrent chemoradiation, but good performance status and minimal weight loss. She has good social support, and she is younger. Discussion by the multidisciplinary healthcare team would be prudent. She may be a candidate for an NG tube as needed if the patient is agreeable. Okay, so finally, despite looking at a fair amount of information and evidence today, there is still a, quote, lack of sufficient evidence, unquote, to make definitive recommendations. I wanted to highlight two excellent studies that show the benefit of RD-led clinics in this area. Hall et al. Has a wonderful article outlining their practice. It's titled Implementation of a Dietitian-Led Enteral Nutrition Support Clinic Results in Quality Improvement, Reduced Readmissions, and Cost Savings. The implementation of this program and the results of their pilot study, when compared to their 22 baseline patients, showed an 88.9% reduction in nutrition-related ER visits, a 78.1% reduction in readmissions, and an estimated per patient cost reduction of almost $7,000. Additionally, Kiss et al. Has a wonderful example of their work, and it's titled A Dietitian-Led Clinic for Patients Receiving Chemoradiotherapy for Head and Neck Cancer, that showed a reduction of nutrition-related admissions from 12% to 4.5% after their program started, a reduction of unplanned NG tube insertions from 75 to 39%, and improved transition to oral diet post-treatment. Although this is not statistically significant, it is an improvement, 68.3 to 76.7%, and reduced radiation oncology review at 2 weeks post-radiation treatment from 32 to 15%. Both of these are inspiring and definitely show the benefit of RDs not only in the care and treatment of these patients, but they take the lead. And there is such a need for more randomized controlled trials to determine best practice in this area. And if nothing else, the presentation today has highlighted that there is a lack of sufficient evidence at this point in time. So in conclusion, today's take-home points are these. At this point in time, there is no agreed upon consensus on indication, timing, and long-term nutritional function benefits of tube feeding in patients undergoing treatment for head and neck cancer. That being said, there are guidelines that will help the healthcare team make more informed decisions on who might benefit from a prophylactic feeding tube. Every patient should be assessed as an individual, and RDs need to be part of the interdisciplinary team, and as seen as in the Hall and Kiss studies, they can actually take a lead in this team and area. And although guidelines should be utilized to identify patients that may be appropriate for a prophylactic feeding tube, ultimately patient wishes and at times provider practice will be part of the decision to have or not have a feeding tube placed. If a feeding tube is placed, education is essential for both the patient and the caregiver. This is key to success. And lastly, following up post-treatment, a minimum of 6 months is recommended, keeping in mind that patients may experience late-term effects from their treatment well after 6 months. Thank you very much for your time and attention today, and we'll open it up to questions.
All right, thank you very much, Dr. That was a wonderful presentation. Although there is still a lacking of some of that sufficient evidence to help us determine when to peg and when not to peg, I think we all have a much better overview of the guidelines that will help us evaluate which patients may benefit most from that prophylactic placement. So thank you very much.